let me tell you a little bit about what we're planning to talk about. I really hope this will be a very interactive time, so that's why I want to go ahead and get started so that we have lots of time to talk about these issues, because we know they're big issues. I'm Rebecca Wilson. I'm a psychologist. I work with the X&Y clinic here in Denver. Erin.
Hi, I'm Erin Bozorgpour. I'm a psychology fellow working with Dr. Wilson.
And Erin has worked very hard this week because I've been seeing a lot of your sons this week, and so we've been very, very busy. And Erin has worked very hard to help put together this presentation. So thank you. Oh, and here's Erin. There's Erin. I also want to acknowledge Dr. Blume. She does a lot of behavioral work with our kids and really helped put together this presentation as well. So I want to talk very briefly about why we're talking about this. We have been doing research at the clinic, and so just quickly, this is actually just a sub-part of a poster that's out there on the window if you want to look at it in more detail. But what we decided to look at is in the kids that come to see us, and adults as well, what are their presenting concerns? This is a subset, definitely a subset of our clinic. If you know us, you know this is a subset. But you can see the number along the top. It's about 90 patients. We're seeing, and these were patients that consented. We're seeing in an interdisciplinary clinic, so saw everybody in the clinic, and for whom we had good clinical concerns stated at the offset of the visit. So what I think is interesting about looking at this, if I can make this work. Whoops.
Here we go.
Oh, thank you, thank you, thank you. Is that you can see behavioral concerns across all sex chromosome differences is a really significant issue. Let me get this to work. I don't know. There we go. So in XXY, you know, 50% of our kids are coming in, our patients are coming in with a significant behavioral concern. And across the different conditions, this is a significant concern. That's why you're all sitting in this room, I know. But I think the other point is, look down here. Conduct is not such a big issue. And so this really flies in the face of that old myth about conduct disorder being a concern. Now, aggression, yeah, we've got some elevated aggression, but this is a biased sample, right? This is a clinically biased sample. You guys don't come to see us unless you've got concerns. So, and you know, in general, you see some of the X and Y concerns here. Poor attention, hyperactivity are also significant concerns. Mood, this is another issue that a lot of people come to us to see with questions about. One of the questions a lot of people have is what age range. This runs from 3 years old to, I think, 23 is our oldest, 24 is our oldest patient. So, and as we know, anxiety certainly plays a big role in social concerns, and so you can see these percentages kind of hang together, and likewise, withdrawal and depression tends to go together. Another big concern that people come with are academic issues, and as I hope by the time you leave here this weekend, you will become well aware that language issues really play a big role in academic challenges. These are the other issues that folks come for, and I think play a major role in behavior, as did everything else that I just kind of showed on those previous charts. But one thing that a lot of parents aren't aware of is how these three things tend to be associated. Now, these are the things that parents are coming, or adults are coming with concerns about. So a lot of times when you're seeing people come, well, I don't have any sensory concerns, some of these may be families that are not aware of even the term sensory or sensory integration. Okay, and final diagnosis. So that was what they come concerned with. And these are some of, just a quick overview of some of the diagnoses that folks end up leaving with. And again, all this data is out there on the poster. Yeah? Right. So, yeah, a good point you're making here is that conduct disorder, not a lot of conduct disorder, right? A lot of concerns with ADHD, a lot of concerns with depression, language disorder really strongly represented, learning disorders, and a lot, again, intellectual disability is one of the reason why people may come to us for evaluations. Yes. Please, ask questions. Yeah. Yes, you.
Okay. Out of my ignorance, behavior and conduct, I'm like, well, what's the difference?
Yeah, conduct disorder is a clinical manifestation of behavioral concerns that meet criteria for a formal diagnosis of conduct disorder. Has to be sustained, difficult behavior that is destructive, or it's a certain level of clinical concern. Yes?
What is behavior? What does that cover?
So yeah, exactly. And I actually did this research myself, and so I reviewed those 90 charts, and I was looking for specific concerns that actually parents would say, we have behavioral concerns. So something that was like that or very, very close to that. So he's destructive, he's aggressive, she's tantruming. What?
Having meltdowns.
Meltdowns. That's probably the commonest. Non-compliance. Right. And this would be a really good time to let's take a quick survey in the room of
so what's the
behavioral concerns.
Behavioral versus conduct. Then?
Right. Conduct meets a level of.
So that's a medical term.
That's yes.
Okay.
Yeah, it's a diagnostic term.
Diagnostic.
Right.
Okay.
So tantrums alone wouldn't get you a diagnosis of conduct disorder.
Okay.
Yeah.
So
yeah.
What was your question tonight?
Okay, just a second. I got one more question over here.
Language and learning, comprehension of language?
So what I did was I lumped together formal learning disorders, people that were diagnosed with a formal learning disability, like dyslexia or reading disability or one of those. Those all fed into that category. Language disorder were expressive receptive language disorders, articulation disorders, those kinds of things. Other questions? Okay, now questions for you. How many people are concerned about meltdowns? Okay. How many people are concerned about aggression? How many people are concerned about habits? How many people are concerned about whining?
How many people are concerned about withdrawal?
Withdrawal. Okay, I think that's a good. Other things, throw out other things you're really concerned about. Anxiety. Oh, that's a good one. All right. And you can see impulse control. ADHD kind of things. Impulse control. Hyperactivity. Not as much. Inattention. Yeah. ODD. Yeah. And ODD is part of this conduct disorder. I loaded ODD and conduct disorder into this diagnostic collection. Oh.
Yes.
Executive function. Yeah, so that would go into the ADHD. I lumped executive function into ADHD, and there's actually more detail out in my poster out on the window, or our clinic poster out on the window, because there's a lot of kind of subcategories that I didn't think you guys needed to wade through. Yes?
I'm sorry, on the previous slide you had a section for behavior, but then your final diagnosis, you don't have behavior. Is that
Right, so this is what the clinical concerns were.
okay?
So this is what, yeah.
So you said the first slide was what parents' concerns were.
All three of those slides are parents' concerns.
Okay.
Yeah.
Behavior was huge, so I'm just saying when you got to the end, you had your final results, I didn't.
Right. So an important consideration, and one of the reasons why we're here talking, is I feel, and our clinic feels very strongly, that we have a unique understanding of behavioral and disruptive behavioral concerns. And that a lot of times we understand them within the context of attention, or anxiety, or a learning disability, or a speech difficulty. So that's kind of our unique spin. In order to get a diagnosis for conduct disorder, if you have an X and Y chromosome condition, you need to I would need to be convinced that it truly is a conduct disorder versus something else. Right. So we really are very...
All those things combined make, like with anxiety, depression, all those different, but
Yeah.
could that make it a...
It can. Yeah.
What is the age range, I'm sorry, for this clinic?
From 3 to 24.
Jill, did you include, for instance, marijuana or any kind of drug abuse in your study?
We would have, it wasn't a concern in this clinical sample. You got to remember that these guys were consented for research, saw a multidisciplinary team. So there's some ascertainment issues we could certainly talk in detail about. That's kind of a different issue. But we do see drug, alcohol, kind of gambling and gaming issues, particularly in our young adults. And we tried hard to make this talk broad enough to get from our 3-year-olds to our 20-year-olds. It can be tough because gaming, I could do a whole talk and almost consider doing that. A whole talk on gaming alone. Who would be interested in a gaming talk? What?
Are you talking about like video games or?
Yeah, video games.
Yeah, screen time would be...
It is a behavior. Yeah. Yeah, I'm sorry. I meant like video games. So that's something I think I may want to do for our next conference is talk about screen time and video games because it really is a very significant concern and I'm actually beginning to collect some data on it. What?
And how to modify that?
And yeah, how to modify it. Not improve it. We don't need to...
No, we want them to not have so much screen.
Exactly. So I'll move on unless you guys have more questions. I'm love that you have questions about our research. That's cool. This is our research. We're pretty excited about it. We hope to publish it soon. That's Spinal's diagnoses. Okay, so what have we learned from our clinic? And that's really why I'm here talking about it. We've learned that our kids come with a lot of speech and language issues. They come with emotional immaturity. They come with social immaturity. I'm not telling you anything you don't know. They come with a lot of social deficits in addition to social immaturity like autism spectrum disorders. A lot of motor skill challenges, fine motor and gross motor for some kids. A lot of sensory concerns, academic challenges, and for some of our guys, testosterone issues. Fatigue, afternoon fatigue, a big issue. Yeah. We would like to know that.
Frequently to see like, you don't do anything. I don't understand what you're tired from.
Right. How many people have problems with afternoon fatigue?
Overstimulation, like in school days.
Wow.
I mean, like
Good stuff. Yeah.
So the OT session we just went to said it's sensory overload.
Yeah, so sensory overload can probably...
or mine does, but my phone.
So we think a number of things probably load into fatigue. One of them certainly is sensory. Another one is testosterone. Another number of them is how hard their whole day is because of all of these issues. But there's also some concern that there's an underlying metabolic issue because the afternoon fatigue syndrome or fatigue really runs across all the conditions and does not seem to just be related to testosterone. Yes?
What do you define sensory concerns?
So that's a broad term of like sensory integration disorder, kids that get over, or people who get overwhelmed by sensory environmental impact of all kinds.
Noise, yes, too much loud, texture, smells.
I would say sensory, would that be like not bearing?
Yeah, it's sensitivity to
fabrics, undersensitivity.
underwear, socks, shoes. Yeah. So quick thing again, how many people have problems with sensory integration or sensory sensitivities? Yeah, really big issue. One of the reasons I really do this is ask everybody this is I think one of the most powerful things about being here is feeling less alone.
Yes.
And really knowing that other people are struggling with the same things, right? You're welcome. So I'm a pediatric psychologist, and we think of a lot of these things as things that are manifest in childhood. But what I know for sure, And I think any of you who are dealing with someone who's an adult, these things definitely persist into adulthood and don't go away just as kids grow up.
I have a question. I mean, certainly us as a group getting
Yes.
together and sharing and understanding that we're not alone is important. But does it help the kids who are like not mature enough to attend maybe at, you know, like 16 and above group to interact and realize that there are other kids that have these same issues?
That's a very good question, and I really think it depends on your kiddo. There's some kids that really benefit from feeling less alone. There are other kids that feel overwhelmed by that or really
Doesn't necessarily help them.
doesn't necessarily because of the immaturity, it's hard for them to kind of have the insight into it that we might wish they would. But for many people, I see a point at which it starts to become important for them to feel less alone.
What age is that?
That tends to be sometime around adolescence.
Adolescent meaning 13?
About. But it depends on your individual and kind of how they see it and whether they want to hear more. There's a lot of kids that are like, I don't want to hear about it. Yes?
Will you get your slide samples?
Yeah. I think they have them. Yeah. Oh, and also, we put together a quick little, this is truly a quick and dirty behavioral toolkit. Take copies.
And if we'll likely run out of copies, but we'll make more and have them available to you.
You can pass that around if you want. And you're welcome to email me. Our emails are at the end, and you're welcome to email us for more copies. Okay, so if you're sitting in this room, my guess is you've read books, you've gone to talks, you've gone online, you've talked to every friend you can ever think of who's ever had a kid, who's ever had a behavior problem. You've talked to grandmothers and aunts and uncles. Am I right?
Yeah. We're dealing with our son with an autism, and the approaches they're taking with him in approaching autism are not working.
Right, and that's how we think we're a little unique.
Yeah.
And that I think we understand some of the things that load into behavioral concerns that other people don't have as good of understanding of. So there are a lot of ways to approach behavior. Right? Go to the behavior section of any bookstore. There's shelves and shelves. Exactly. So what Aaron and I are going to present today is just a very simple approach. Something that everybody can remember. Hopefully everybody can get on the same page. You can use across settings and with across ages. I'm not saying this is the end all and be all. It's just one approach, one way for us today to talk about behavior. Does that make sense? Okay. People familiar with the ABC approach. A, the antecedent. I want you to think about what happens before the behavior. B, what we do or say. Consequence, what happens immediately after. The part that's a little unique is your relationship with your person. How you're driving these behaviors. The role you're playing in these behaviors. The roles you're playing to promote positive behavior and the role you're playing to decrease negative behaviors. In my opinion, you need more. Okay, we'll get more. Would you mind going out and asking Tania? Does she have it? Oh, she doesn't have it. We'll get more printed today. We'll have them by tomorrow. How's that? We'll have them at our clinic table. Okay? Yeah. In our experience in the clinic, your kids and your adults with X and Y chromosome differences are uniquely sensitive to relationship. And I see this every day in the clinic. And I really ask you to pause and think about your relationship with your person and how you affect the behaviors that you're concerned about. The other thing that I think is important to consider are X and Y chromosomes, the differences that they make on the situation. We're quickly going to go through the ABCs, and then we're going to talk a lot about X and Y. We all know what antecedents are. And here's the thing. You're here to talk about this. You're here because you're concerned about this. This is what I'm concerned about. And this is what you should be concerned about too if you're concerned about behaviors. The behavior is the tip of the iceberg. It's the least important thing to think about, frankly. I mean, I know you're concerned about it. I get that. But I think really thinking about antecedents is what I think about. Now, let me say just quickly, I'm a clinical psychologist. What I do every day of my life, and have been doing for about 19 years, is I test kids. Kids don't want to do what I ask them to do, right? So, turns out I do know a little bit about behavior, and I have to practice this every single day across lots of kids, doing lots of stuff. And if you've worked with me, and if your child's worked with me, for the most part, kids don't leave unhappy. We don't have major temper tantrums, and they seem to work with us. But it's because we kind of know how to work with behavior. So if you're here, this is probably what you're thinking about. Negative behaviors, right? Right? Yeah. But there's also neutral behaviors. And I'd also ask you to think about your child's positive behaviors, because your child has lots and lots of them. So for a lot of you, the classic neutral is sleep, right? That's the thing we think about, right?
They're angels.
Love them when they
So great when they're asleep.
hold them all.
But there's another parent in this room who's right now saying, my child sleeps too much.
Yeah.
This is a problem. There's people that think of positive behaviors, my child's brushing their teeth. For other parents, it's like, well, that's a neutral behavior. They've been doing that forever. That's not that big a deal. Or they don't ever do it, and so then it becomes really a problem, concern. So the idea is simply to increase the positive behaviors. You only have so much time in the day. If you increase positive behaviors, what's going to happen? The negative behaviors have to reduce. So one of the things, and this works, research shows it really works, is if you increase positive behaviors, just by nature, the negative behaviors have to reduce. Okay. Consequence, we know what consequences are. Everybody's thinking right now about the most punitive consequence you can come up with, because that's what we end up doing, right? But really what I want you to do is think about the way a consequence either makes behaviors more or less likely to occur, and the kinds of consequences you use. Did you want to make any points about this, Erin?
Yes. I think one of the most powerful things when thinking about what happens after a behavior is what, what the function is. So people are wanting to get, most likely people are wanting to get something out of it. So I think that's an important thing to think about.
Right. And what?
Are you talking about the child or the parent?
It could be both, because there's a relationship dynamic. So you think about why is somebody doing something, and why is somebody responding is because you're either trying to get something or you're trying to get out of something.
So a consequence can also be this, right? The first thing we think of is something negative. Positive consequences, by research, by every way I can think of, tends to increase the behavior you want.
So what we know is that if you notice what your child is doing, if you notice all the neutral and positive things that they're doing, and you can label that specifically and tell them and show them that you can see that they're doing really good things, what we know is that it's nice to hear what you're doing right. And so if you do that more often, so if you say 5 positive things, and then you give 1 correction, it's a really nice way for people to feel like they're capable, like they're independent, and then it also strengthens your relationships.
So I want you right now to commit to trying to use positive reactions. Not only maybe with the person that you're here for this conference for, but with people in your life. It is one of the most powerful things you can do, is notice them doing something good, catching them doing something good. Catch your husband, catch your wife doing something good. It is incredibly powerful. Catch your psychologist doing something good.
Thank you for today.
You're welcome. See, I feel better already. Okay, now I want to start talking about some of the specific behavioral circumstances. And this is what I call the ABC snowball. This is the idea of a behavior that snowballs on itself. A meltdown that the problem is the meltdown. So, and I bet you guys can relate to this. The trigger is insignificant. It's so insignificant, you don't even know what it was.
Right.
I've talked to some parents today, several parents today, about I don't even know why my kid's upset. They're upset. And I'm not sure that he knows why he's upset. Then the behavior starts in, right? They react. Our kids are sensitive. That's that sensitivity, emotional immaturity, sensory overload. So many things can make this little tiny trigger a big deal. And they start to get upset. The next thing that happens is their frontal lobe shut down. Now all the impulse control is shot. They're not planning. They haven't even thought about what effect this tantrum is going to have on the thing they wanted to do next. And then they start thinking, oh, I'm stuck. This is going to happen. I can't do anything about it. And they melt down. Right? Yeah. Then the dysregulation, their heart rate starts going up. They start sweating. They start reacting to the meltdown itself. Not this little tiny trigger up here, but the meltdown itself. The tantrum snowballs, and now they're really upset. You're really upset. Your person hates this feeling, and you have a major meltdown about a meltdown. How many people have had this happen? Right. This is a really big deal in our people. And it's one of the reasons, like when Robert Jr. was talking about autism interventions not working, a lot of people in behavioral fields don't have a good understanding of these links in our kids and how all the different things that are areas of deficit for them really play a role in their meltdowns. So the idea here is that we've got a habit going. We have an antecedent associated with a negative behavior like a meltdown. What we want to do is interfere with that habit connection and make the antecedent trigger a more neutral behavior. Here's what you are typically dealing with. Your kid comes in with, and you can fill this with a huge stack of bubbles. Tired, mad, hungry, language overload. Language overload, language overload, language overload, language overload. Can't say it enough. And you just got overloaded. I can't tell you how many of us will try to work with our kids with language. Let's talk about this. It's too much. So the typical thing is, no, don't get upset. No, really, no, wait, it's going to be okay. No, I'll tell you what, if you don't melt down right now, I'll get you. By now, it's too late. Your kid's overwhelmed. They don't know what you're saying they will get if they do this or that. And I bet all of you guys have seen that in your kid. Right? And you become like, wah, 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 wah.
So in many respects, you have an expectation for how they're going to react, and they have an expectation for how you're going to react. So that's where the relationship piece comes in.
Exactly. Yes?
I have a question that's kind of related to this. Like you said, like to make it positive. And one of my son's therapists, coping mechanism that he learned is before he's going to have that meltdown,
yeah.
He's pretty good at doing it. It's like, I'm going to take 5. Okay?
Right.
But because of his impulse control, I'm afraid to leave him alone. Like he's like, I need to go take 5. Like maybe he's going to go, he wants to go to his room or he wants to go in another room. And I'm afraid because he's upset, he's impulsively going to do. But if I go into his space, I'm not giving him that take 5.
So
it's like
can everybody back there hear?
That he's trying to use to not melt down, that he's been working on.
Yeah.
And it's a positive thing, other than, he's not melting down, which is a good thing. He's like, I'm really, I'm here, I need to take 5.
Right. So the way you do that is set up an environment that's a good take 5 environment, but maybe kind of a supervised situation.
He wants to do it.
Right, and that's part of the problem. So that's when collaboration comes in. Okay. I know you want to.
Security cameras.
Right.
Like his room, like
baby monitors might work. So you try. I know, and you're dealing with a really complex situation. But the ideas in general would be collaborate with your son to find a way for him to take 5 that's appropriate and you feel is safe and comfortable. So take 5 is not outside on the street.
Right, locked in the bathroom. Or
Right, right. And then make it a great place to take 5. Not just, okay, you can have the corner.
closet.
You can't have the closet, right? You can
No,
have
I'm kidding.
the locked basement. No, just kidding.
And a lot
I'm
of
totally
that,
kidding.
a lot of that involves setting expectations up ahead of time. So that
Right.
you,
Before-
so,
yeah,
so when
before
your
this
son
meltdown,
or
like
when
when
your
they're-
kiddos are calm, then you talk about very specifically what the expectation is. So he can, and if you
He
can
knows
have
where
a
to take
coping
the
corner,
5.
he knows where it is, you make it really cool, so that you can support him with that coping skill he's working on. I see another hand back there.
Yeah.
With our son, one thing that we found that works is when we see him starting to escalate, we'll take him and either wrap him in a tight hug or put him on our lap
Perfect.
and give him a tight hug.
How old is your son?
He's just turned 10.
10. Yep.
And that tends to de-escalate him.
So here's a point I'm making about a kid who's 10. It's important for you to understand it's okay with a 10-year-old to do something you might really do with a younger kid, as long as you're not humiliating him.
Right, we're not physically restraining him, he just needs
Just
that
hug.
sensory of, and then he knows we're not mad at him.
Yeah.
And it de-escalates.
And you
is what
figured
we
out
do.
what works for him, and so that it's a successful resolution. Things
That's
are
right.
working better.
So one of the things you can do is start to change that up so it's something he could do for himself. So maybe he knows he needs to have a hoodie with him that's pretty heavy, and you might even make it a little bit heavy so he can put that hoodie on when he's upset and pull up the hood and zip it up and do something like that. Yes?
My grandson is 10, and he started building taking sheets and creating a tent in his room. So my daughter found, it's called a pop-up tent.
Yes.
And she has it on the bed, and it has zippers on both sides.
Yes.
So it's open, and that's the rule. But when he has a meltdown, he just goes in there and he closes one side. That's the rule.
Perfect.
And that calms him down.
Perfect. Yes.
Our daughter had a lot of meltdowns before she was on Lamictal for seizures, and
Yeah.
that changed her behavior dramatically. But when she would have them, and she still does occasionally, she did not want to be hugged. She wanted to be left alone.
And yeah.
Don't touch me. She'd go to her room at 95% of the time. After meltdown, she'd go to her room, go to sleep. It was almost like unplugging the computer.
Yep.
15 minutes later,
Just fine.
new kid.
Yep.
It was just like resetting everything.
Resetting the executive functioning, resetting the sensory, resetting really the autonomic nervous system, right, is really what you're doing. And actually you bring up a good point, because I think I really could put medication in here, different medication for different kids. Certainly I'm not saying just Lamictal, but that can make a really significant difference to kind of break the habit so that the kid doesn't feel like every time I'm upset, I'm going to melt down. Let's have an interaction here. I'd love to hear more ideas that work. Yes? Or don't work.
No, this may be totally different, but it's really relevant in our life. We've gone from having the meltdowns, and I'm sure you don't remember.
I do
4 years
remember
ago,
very well.
Four
Yes, I
years
do.
ago, when our son was huge then, and we
yeah.
were having meltdowns. But our problem now with a 19-year-old, and maybe some of you other guys are feeling this, is gone from meltdown to motivation. He never has any meltdowns now, so he just will lay in bed. No, that's not good, because life has to carry on somehow.
Oh, motivation. I think you're saying he's motivated to go do something.
So it's not the opposite.
He's withdrawing. Sorry, I thought you were saying he's not, I thought he was motivated.
It's like, how do we get them
Motivation
interested in
because-
doing anything?
Just
Right.
not doing anything. He has no motivation to
Right.
get out, to be involved in any social activity, in any school, any bettering himself.
Right, and this is another huge issue. It's the negative withdrawal symptoms.
So-
Huge issue, and one of the things we probably ultimately struggle with the most in our young adults.
Yeah.
You guys have a very complex issue, I know. And again, I mean, there's lots of different ways to manage. So you've got the opposite problem. You need to stimulate rather than calm. And one of the things I just want to say briefly for those guys that are dealing with younger kids who are doing a lot of this, in my opinion, one of the things that's beginning to happen that I'm beginning to see in the clinic over time is that kids that have a history of this begin to feel unsuccessful.
Yeah.
They begin to get discouraged. They begin to feel like anything I try doesn't work. And so they start to shut down. And for the kids that are dealing with testosterone issues as well, I think that that is part of the whole puzzle, but not all of it, obviously. So one of the things that I would do is anticipate the things that are likely to result in the meltdown withdrawal, so you're talking about meltdown withdrawal, and catch him before that happens. So when these things are building up, he's getting overwhelmed, a lot's feeding in, and I know that this can be very minor in some situations. It may not be all that much that triggers them, but trying to keep them better regulated so they don't withdraw as a reaction to it.
And sometimes that takes working with a combination of providers to see if there's multiple options that can be helpful.
One of the things we're doing is trying some medication.
If, just a specific instance is coming out here, which there's excitement about coming out here, but then when we get on the plane, or then we have to get up and get to the airport. Well, I don't want to go there anyway. It's stupid.
Yeah.
Well, geez, we bought 3 airline tickets. We've got hotels. We pay for the conference. I never wanted to go anyway.
Right.
Which is just a way to get to engage what you were talking about to bait us into some big meltdown, so to speak. But it's a different kind of meltdown than we had with a 12 or 14-year-old.
Right.
Now the meltdown is this.
Right. And they get a lot more control. That's right.
You're right. That
Absolutely.
Control,
Absolutely. And some of this is all about getting some control.
So Helen, this passive-aggressive kind of thing, and even this morning, had a good time last night. We're hopeful. We're good. We're going to get up today, and we're going to have a good day today. Made some connections with friends. And, of course, we roll in 45 minutes late today.
Because you were trying to drag him out of bed.
250-pound guy over my shoulder. Plus it looks silly.
It's the silly part we're concerned about. Yeah.
That might have been an overlook. You said that you thought it was a very successful day.
Yeah.
Maybe he needed some time to pull back.
So a lot of times they need little tiny steps, right?
Go back into it because that was,
That's, yeah.
We can't put them on our time schedule.
Right.
Sometimes it might be that.
Well, and speaking of not being alone, and I know there's a few people faces, we've already met some folks with some people that are 17 to 25-ish. Do you guys face that? I know people. Yes.
How many people face withdrawal motivation issues? Can't get them out of bed. How many people can't get them out of bed? Right. How many people have afternoon naps that are interfering? Yeah. Yeah.
One observation, and that's just what it seems like it's the case with my daughter, who does an awful lot, not just fatigue, just sleeping. To me, it's just an avoidance technique.
Absolutely.
If I can go back to bed and they think I'm asleep, nobody's bothering me.
I'm going to have a meltdown and avoid doing homework and chores.
Absolutely. And it can be a meltdown or a withdrawal.
The meltdown that leads
absolutely.
To my room and go to bed.
Yeah. Go. Uh-huh.
So a lot of things, I come to the parent side because I had XXY. I had an easy childhood, so compared to what a lot of children go through, I didn't have a lot. I had homeschool, I had small classrooms, I had help here and there. My mother's actually doing the child care, and she does teaches children special needs. All this, so I had a lot of help growing up, even though I wasn't.
Sorry, I'll move back.
But in terms of mood and motivation, things like that, I have experienced that, but what it's experienced is when it's on the lower dose of medication. When I'm improperly at my levels, taking the testosterone, more than that, the motivation issues are not there so much.
Right, right.
And when I'm at a low or low in the medication, then motivation becomes more of an issue.
Right.
But when those levels are up or a little higher, or even a little higher above normal, then those issues, motivation, things like that, getting up, sleeping too much, or this and that, they're no longer there.
Can I ask you, do you sometimes feel overwhelmed by what you have to face?
Not so much. I've been driving the school bus the last 5 years. I'm still going to my uncle's company. There's still struggles I have here and there with the downsides to the XXY, but there's things I'm working through.
Right.
The medication being there is a big advantage and it helps a lot.
Right.
And if people have questions and this and that, I like to share because based on my experiences to help them.
Oh, we so appreciate that.
What medication?
Do you use
injections?
I do injections. It's actually do a modified injection versus the 2 weeks where you have the peak and then the drop off.
Yeah.
I did a self-modification where I take a CC in the first week and then I do it every other week. So there's always something in the system so you're never dropping off and having that crash or face. So it keeps a more balanced, injection. It keeps more in your system. I tried the gels. I didn't have the absorption, copay and that. Now I don't have insurance. I pay for it and this and that, and I don't. I have a specialist at OHSU, but without the insurance, I haven't seen him over a year. So, I work out with new companies that want to get blood work, but we see him, a couple times a year. But the rest, I just tell my, the family doctor, he writes prescriptions and it's basic overview and has a little bit of contact with the specialist. But most of it is all personal. I've experimented with the lows, the highs. I've tested. I let myself go to an absolute crash.
Right.
Got blood work done to see where those levels will be, and I'll tell you that I have the ability to take a stance back and see how it's affecting me.
You have some insight into it, yeah.
And you can go from a extreme low of, you could go anger, wake up angry and enraged, and
right.
at the moment just throw something across the room, or go to extreme depression. And then, but once you're on treatment, it's, the medication, it makes you go back to normal. But,
right.
For me, I can take a step back and say, this is not me, this is not how I am, and analyze how it's affecting me.
So for people that can have access to, or that testosterone is a treatment, I can tell you from my experience, I have had lots of men say, getting some insight into when they're low and how to get regulated on testosterone does make a big difference for this issue. I know there's other people sitting in the room who are frustrated because testosterone's not what they're going to get help from.
There's
right.
other things, like I have, I'm ADD, and I have medication for that.
Yeah.
But in terms of keeping my tolerance and this, I take it only as I need to. Sometimes none, sometimes more. If I feel myself building a tolerance to it, I'll just drop it for 2 weeks if I can afford to. If I'm not working like Christmas break and I was driving a school bus, I just completely drop it and let the body so it doesn't build a tolerance to it.
Right.
But it also helps with the motivation for me.
And stimulants can make a huge difference in this kind of withdrawal meltdown habit. Because I think that what happens is, what you've done is you've broken the habit of withdrawing as a way of dealing, right? Sounds like it was never a big issue for you.
It wasn't a big issue for me.
But it could have become.
I was socially, I was homeschooled this and that, I was lonely, but in terms of social groups, I didn't care.
Oh, yeah.
I was happy that I was alone. I was doing my own thing.
Right.
I found other ways to compensate for, physical strengths, this and that. Like, since 2000, I've been playing paintball. It's a team sport, it's an individual sport. You don't want to let the team down, you go out and do your own thing. It's your own personal accomplishment. If you're angry, you can focus your anger and just go, I'm going to hunt down this one person. I'm going to try and do this and sneak around. You can focus it and be productive with it. There's also a great family there. It's very supportive.
Yeah, so getting involved in some activities can help. And I think that one of the things that you really, if you're struggling with withdrawal, is really I think you're right, think about what's overwhelming about the situation and can you break it down? Can you work with them in smaller pieces? Can you modify it in some way so that the reaction isn't to withdrawal? Because the passive withdrawal is very, very powerful because they learn they get a lot of control with it. And a lot of it is just breaking the habit so that they find out that it's actually great not to withdraw. And actually, if you stay with us, you'll get to do some things. What you want to be careful about is if you're working on withdrawal and shutdown, have him experience what it's like if he stays and have it not be overwhelming. So you can set up some situations that you think he thinks is going to be overwhelming, but then modify it so that it's not so overwhelming, so he doesn't withdraw, reward it, reinforce it.
So you start small.
Yeah.
And then so that you
Good
can
point.
build up to bigger and bigger successes. Because I think it can be really hard if, maybe, somebody's not even conscious that they might be feeling afraid or worried or exhausted. They might not be able to articulate that. So just really setting these really small, reasonable goals can help.
I find this interesting because now I'm seeing where a lot of this no medication whatsoever. And
Oh, go
very
back.
apropos, it's coke and the type of glass we're using.
Is it?
At 18, I started drinking.
Ah,
And everything that was bothering me, all my anger issues had to do with usually schoolwork. Where a problem would be described as class, mostly math, and that was my favorite subject. And the thing would be described in class, oh, that's so simple. And get home and try to duplicate it,
yeah.
and I would get angrier and angrier. But there was also withdrawal.
Yeah.
And a bunch of other stuff. And at one point, I hit 18, still hadn't hit emotional
Immaturity.
And Mr. Ruts in the family. I went
Started drinking. The other thing that we're seeing is drinking, drugs, and gaming here. Glasses, yeah. Didn't mean to do that, but I hope not. And the other thing that I see a lot of guys doing is, and some of the girls too, they're doing video games as a way to escape, and that becomes their coping mechanism, their coping skill to escape into video games. And once that happens, it does tend to be a downward spiral unless you can manage it. Yes.
Earlier we were talking about a lot of kids, people that have elementary school, middle school kids, have ways that they are coping themselves to deal with the mouth. How do you, number one, how do you transition from me being the coping mechanism to them facilitating coping? We started the counting, the singing,
Right.
the humming, and it's I hum, I sing, I count. How do you make that transition to, your child says, I need 5.
So you would love for her to start doing that, but yes, let's have some other ideas.
Instead of me saying you need 5, instead of me giving her the hug, the restrained hug,
Right.
she said, how do I transition from me being the coping mechanism to her
Yeah.
being the coping mechanism?
Good question. Let's talk about that.
I would say I can maybe help with
Yeah.
that, because my son, just a little background, went through partial hospitalization program where he learned coping mechanisms, but then obviously that was just a partial thing. So then at home, we have it like on the refrigerator, and then he picks the ones, like he's in control of the things that will work for him. So when I would drive him to school, I'd say, okay, so if this happens at school, like if recess, I would give him situations if Leah can't play, and you already make sense with her and she can't play, what coping strategy are you going to use? So you start out with pre-seeing what could happen.
Do you have the list and you allow them to take the list?
Well, no, I'm saying he has the list on his door, on our refrigerator, it's around the house. Like, when we're going into a social situation, be it dropping him off at school, dropping him off at Scouts, going on a camping trip, whatever he's doing, we talk about what might come up and what does he think he could use for coping strategies. So having those conversations, I'm not saying that he never has any meltdowns anymore. I'm saying that, so I have those conversations to kind of stop it from happening in the first place. Sometimes it happens anyways, but because we've already had so many of those conversations, he stops for a minute and says, I need to take 5. Because then he's remembered that we've had those conversations. We have those conversations like several times a day. And before he goes outside,
Right.
after at school.
Anticipating, that's great.
Unstructured social situations are difficult for him. So
Right.
when you're going to go outside, you and Michael make plans on the bus to play capture the flag. What if all the kids are playing kickball?
Yeah.
How are you going to handle it?
Remove all that verbal.
Right, and that's,
So you can use, that's a great question. So there's visual strategies we know really, really work. So you can give a couple choices, whether
Yeah.
it's a picture or just like you're doing, can really help move so that the behavior that you want to see will eventually become
their
habit.
behavior.
so
Their
visual
habit.
schedules, visual pictures, asking her to do it herself, like
Making the choices.
count with me, make the choices, fill in the blank. I'm going to get into a lot of those. I'm aware that we're running over. We started late.
When they're not,
And so if you want it in an effort to structure the environment a little bit, if you want to leave now to go to another talk, I totally understand. If you want to stay and talk more about behavior, we're here all night.
I think she's